I will now introduce our second speaker, Dr. Ryan Zarychanski. Dr. Zarychanski is a hematologist, critical care physician, and clinician scientist at the University of Manitoba and Cancer Care Manitoba. His research focuses on the hematologic aspects of critical illness, where he leads several national and international randomized trials in the fields of sepsis and transfusion medicine. Dr. Zarychanski is the chair of the COVID-19 clinical trials team in Manitoba and serves as the chair for 2 international trials evaluating anticoagulation strategies in COVID-19 and sepsis. Dr. Zarychanski.
Hi there. Thank you very much for that introduction. And thanks for the invitation to speak here amongst many great invited speakers. I'm going to talk a little bit about anticoagulation trials that I am familiar with and following on the footsteps of the presentation you just heard. And so I'm going to really focus on a multi-platform trial that I had a role in leading that forwarded some of the data that evaluated the hypothesis of thrombosis, which we thought was prominent at the beginning of the pandemic, which may be less so now. But what was really important is this concept of D-dimer. And we recognize that, okay, even if everyone's not at risk for thrombosis, some people appear to be, some people are. And can we use D-dimer to help stratify, or could we identify those people at higher risk? Number one, that's sort of prognostic enrichment. And can we then, if we identify a group, can we treat them differently because they have a different D-dimer? And we don't know this at all. It was really suggested early in the pandemic that we measure D-dimer in everyone like it's somehow a novel biomarker in sick people. But then we didn't know what to do with the information, which I always thought was a little bit odd with the recommendation. And then there was these observational studies, some of which were alluded to, and I just picked one because I particularly find it unfortunate because it really highlights the issue of confounding by indication and survivor bias, where observational studies showed benefit, and because people often survive to get anticoagulation and it was indicated for whatever cause. So we really needed randomized trials to help move the data, move the field forward. And we hypothesized that if we provided therapeutic anticoagulation to hospitalized patients, that we might improve their outcomes, irrespective of thrombosis. And we were really interested in the idea of anticoagulation, particularly with heparin being an anti-inflammatory agent and an anti-thrombotic agent, obviously. Sort of this idea of thromboinflammation that you heard about in the introduction to today. And so to help answer this question, we formed something called a multi-platform trial. And the multi-platform trial is a collaboration of 3 independent platforms. And so you'll hear a lot about platforms in the next few years, because the idea, the concept, and the operation of platform trials really came to fruition, I think, in a really large way in COVID and clinical trials like COVID. And so there was a platform trial that I started with my colleagues, Ewan Gallagher and Patrick Lawler and others, called ATTACC, where we were evaluating heparin, therapeutic dose heparin, in ward patients. So we call them moderately ill patients. They're on the ward, not on organ support or not ICU-like patients. And then we had also started, myself and a colleague started a domain within a platform trial called REMAP. That's not important what it stands for, but it was a embedded domain evaluating therapeutic dose heparin in critical care of COVID. So ATTACC was on the ward and REMAP was in the ICU. And then the NIH came knocking at our door and really wanted, they were kind of charged with developing a platform trial for the United States, funded by the White House. And they essentially adopted the protocols that we started in ATTACC and REMAP. We collaborated and we made small changes along the way to make everyone happy. And we really were a combination of 3 independent platforms, all with one harmonized trial protocol on the ward and in the ICU. And so what a great concept for global collaboration. So 3 independent but collaborative platforms now with a harmonized protocol, common primary outcome and secondary outcomes and safety outcomes, all working together to quickly answer this question of therapeutic dose anticoagulation in moderately ill, that's ward-based patients, and severely ill patients in the ICU. So who do we study? So we studied adult hospitalized patients, and there are some like small nuances. I can answer any nuance you want, but I'm just trying to distill it down to a message as well. And so the patients were hospitalized for COVID, so they had respiratory signs and symptoms of COVID, and they had to be enrolled within 72 hours of admission or test positivity. It's not and but or. The exclusion for REMAP in the ICU was 48 hours, and on the ward actually it was up to 14 days for that platform. So there's a small difference in that platform. The exclusion criteria are varied, but they really come down to like you weren't at high risk of bleeding, or you didn't have a contraindication or you didn't have an indication for therapeutic anticoagulation already. And so they were actioned different ways, but those are essentially the exclusion criteria. And dual antiplatelets was a common exclusion criteria as well, I might add. And so the intervention was therapeutic dose, low molecular heparin or unfractionated heparin, however you gave it to treat VTE in your center. And the control was usual care pharmacologic prophylaxis, however you gave it as well. And it wasn't like protocolized because there was this shifting concepts of appropriate pharmacologic prophylaxis throughout the pandemic, where it started out as normal, like started as regular low-dose prophylaxis, and then there was panic, and then people said we have to give intermediate, and then some people bled in their heads, and then we said, okay, well, let's go back to what we normally do. But UK decided to still use their intermediate dose and defined it 36 different ways, and so there was some different pharmacologic prophylactic strategies for sure. And so we just studied usual care. And the duration was up to 14 days of hospitalization or until liberation from supplemental oxygen in one of the platforms, whichever came first, or discharge from hospital. And so the platforms were like 96% homologous and 100% in the most important ways. The primary outcome was an outcome called organ support free days. And organ support free days, I just want to spend a bit of time on this so everyone understands it. It's not as hard as it sounds, but it's definitely a new kind of description of an outcome. And so it's an ordinal scale, so it's not continuous, although everyone wants to make it that way. And so it's ordinal scale that ranges from dying, and you get a -1 to 21, where and 21 really means no organ support at all. So that means you stayed on the ward. You didn't need ICU level of care. And anything in between is the amount of days that you were free of organ support. So if you were ventilated for 15 days, you would get a 6. Okay, because you had 6 ventilator free days or organ support free days in that case. Or I use ventilation as an example, but organ support could have been non-invasive, high flow in a small portion of patients, ECMO or pressors, not renal replacement therapy, by the way. And that mimics other support measures anyway. And so this is a very important outcome because it's something that can be used in the ICU where it really measures the days of organ support, and it can be used on the ward where it really functionally measures, do you go to the ICU or do you get to need organ support wherever you receive it? I hope that's clear. This secondary outcomes were like safety, major hemorrhage and hit, as you could imagine, and efficacy measures that are all predictable and not that interesting, but important. Mortality, intubated, not just organ support, but intubation, major thrombosis, hospital length of stay. things like that. I talked that it's an ordinal endpoint, organ support-free days, that includes mortality. It's calculated as a cumulative using a cumulative logistic proportional odds model because it is ordinal. It's, it's controlled for site, for time, because, our treatments change over time, and the people getting admitted to hospital change over time even, and controlled for sex and age as well. A shifting pandemic, probably many more RCTs control for these kind of variables that could change over time as well. Ours did. It's a Bayesian trial, and I won't get into that too much in this presentation, but suffice to say we had no preconceived notions of whether heparin would work or not. So those are called neutral priors. And we incorporated something called dynamic borrowing, where like or very similar information amongst severity groups or D-dimer groups could be used so that the trial could be stopped as quickly as possible by improving the power, or really the precision within a certain subgroup, and it allows us to moderate the treatment effects so they're not extreme too. So it averages them to the green or regresses them a little bit to the mean, because if you stop a trial early, you can have extreme values that aren't replicated at the end of the trial. Okay, and so interpreting the proportional odds model of the ordinal scale is, so red is death, so red is dead, and so and that is a -1, and dark blue is 21, and those are people who never were on organ support, and the odds ratio is calculated by the value in this case of death compared to anyone who survived. So that would be anyone who gets 0 or higher, to be honest. And then the next group is calculated to 0 or death and 0 compared to everyone else. So it's calculated ordinally along the way at different aspects of the scale. And that's how you get an odds ratio. And you compare the probability of a pre-intervention compared to one post-intervention, and the difference would be the probability of that would be the difference of the probability of some event occurring, in this case organ support free days, between the prior and the posterior probability. Okay, we calculated this as for severe critically ill patients, and within the moderate group, we were really interested. Our a priori stopping criteria were split between a high D-dimer that's greater than 2 times upper limit normal, and a low D-dimer, which is less than that. Because we wanted to know what the hypothesis was, does D-dimer make a difference? We wanted to test that. We stopped the trial if we were 99% certain that the therapeutic heparin was better than control, and we stopped if there was a low chance that there was what we thought was a clinically relevant difference, and we could stop separately for each D-dimer stratum. Okay, that just tells you a little bit about the platforms, some leadership, some funders, different countries, different sites, different statistical coordinating centers and data coordinating centers. But all the data, this is not a meta-analysis, all the data, line item, like line patient data, is fed all through each of the platforms to one statistical group in the United States. Okay, we stopped the moderate state on block. That means for both D-dimer strata, that is the high D-dimer and the low D-dimer, for superiority. So therapeutic dose heparin was better than usual care in January, and 1 month prior to that, we stopped the severe group for futility, where therapeutic heparin was not better than usual care. And in fact, there was a high probability it was inferior to usual care. These papers, the severe is submitted for publication and is on a preprint server. It's very close to being in the finalizing, the review stage being finalized, and the moderate state paper is written as well. and it's and so I can't share everything in its sort of publication format, and so I'm going to show some of the results that are in a different format, very mature data that is in line with the adaptive, or another way of saying that is interim, but the adaptive results that are prior to final publication. And so the final group enrolled, there was 2,231 patients randomized to the moderate group, over 1,000 in severe. There's a few outcomes that we couldn't account for with patient transfers. So the final patient group is just about over 2,200 in moderate, and just over 1,000 or almost 1,100 in severe. I can answer any questions about baseline characteristics. I'm looking at them now on a different screen. They're balanced. They're a large randomized trial. The average age was around 60. ATTACC score was around 13. 3/4 were invasively or non-invasively intubated in severe, invasively or non-mechanically ventilated in severe. The D-dimer, which is a little bit of a non-perfect measure because of different assays, but the median D-dimer was around 800 in severe, 600-ish in moderate. I could answer any other questions that people have, but I just want to say that the outcome of organ support-free days functions differently according to the severity state. So in severe at the bottom, it functions as sort of either you're dead here, this is -1, or the days of receiving organ support. But in moderate, it really functions, you can see, in a binomial way where either you die or you don't ever require organ support. And it's actually a combination of 21 and 22, just measured differently in the platforms. So it functions a little bit differently. That is, you don't require organ support, or you do in moderate. So the extension is, can you prevent critical illness or the need for organ support? And in strained hospital systems, that's really important, especially when it incorporates death into the outcome. And so this is the near final results of the multi-platform RCT, where we published this in their sort of in public release at the adaptive results, and they've been updated along the way, and you'll have to wait a little bit for the very final published results, but these are essentially where they are going to land. Where in severe illness, heparin doesn't make a difference. These are proportional odds ratios, and a lower odds ratio is more mortality and less organ support free days, and higher odds ratios are more survival and more organ support free days. And so in any of the D-dimer groups, low, high, or missing, or that really is unknown because it wasn't measured, heparin has an advantage where it increases survival and organ support free days. And remember, it functions a bit as a dichotomous there, so that by extension really means it prevents progression of critical illness. And in the severe, or the group with organ support at baseline, defined, as I said, with high flow, non-invasive, invasive, or ECMO or pressors at baseline, if you start therapeutic dose heparin at that time, there's no advantage. And in fact, there's a high probability of inferiority where therapeutic dose heparin is worse. And likewise, in the all moderate group or in any other of the D-dimer groups, there's a high probability, like 99% posterior probability of superiority. This is the horizontal heat map plot, which I won't go more into right now, but suffice to say there is more red, so there's more people who died in the severe group, less people who died in therapeutic anticoagulation in the groups. Not evident in this top one because it's not adjusted for age, sex, time, site, or the statistical borrowing. But there's an advantage that's consistent amongst all groups as seen by the odds ratios here. Mortality on its own was in the right direction for moderate, and in the wrong direction for severe, with mortality, with posterior probabilities that weren't quite as high because the groups were smaller just for mortality, because mortality is relatively not rare, but it's only like 5% of patients or so in moderate, where it's like 40% of patients or 36% of patients actually in severe. I think that I'm not going to present the data for the rest of the moderate results on the screen because they're still under review and that, but I will say that there's a an absolute difference in survival and survival to hospital discharge without needing organ support, and so that, like, as again, organ support functions dichotomously. So you can prevent about 4.6% of patients from ever needing ICU level care or surviving. That is, survival or ICU level care with therapeutic dose heparin compared to usual care. And likewise, those are important improvements in survival without intubation specifically. So not even organ support, but specifically intubation. Survival without hemorrhage, survival without thrombosis, and survival to hospital discharge. Major bleeding was low, and so there was, like, I think about 1,080 patients in the therapeutic heparin group, 1,046 or 50 in usual care here, and about 500-ish in each of the group in severe. And yes, there is like a higher hemorrhage rate or major hemorrhage rate in therapeutic dose heparin, but they're low, right? Overall, right? 1.6 compared to 0.9. Likewise, even in the ICU, 3.6 compared to 2.4, which I think are rates consistent with, in the severe state, with inspiration, as I recall as well. And this is major thrombotic events or death. There was no difference in major thrombotic events or death in severe state, and a 2% reduction in major thrombotic events or death in the moderate state. Thrombosis in itself was a low event, like 2.5% or so in moderate in the control group, and just under, like, about 1.7% or so for those who are interested in moderate. So low doses of thrombosis, low event rates of major thrombosis and death, 8 versus 10%-ish. So the conclusion in moderate state is that in hospitalized patients not receiving ICU level organ support, therapeutic dose anticoagulation increases the probability of survival to hospital discharge with reduced need for critical care or ICU level care organ support. And results that are improvements in morbidity through organ support and mortality, which are components of the primary endpoint. Low rates of bleeding, and again, like I treatment effects modest in the low dimer. I shouldn't have said it that way. I should say that the absolute difference is lower in low D-dimer patients because the event rates are lower, but the relative rates are actually quite consistent across the D-dimer spectrum. And in severe patients, that is, those receiving ICU level care or organ support at baseline, which I've defined several times already, but I can again in the question period. Therapeutic dose heparin does not improve organ support free days. In fact, it's high probability of inferior, and I wouldn't use it in that patient population. The preprint for severe is online, and the publication should be coming soon. I don't control all aspects of that. A question that comes up a lot is what to do with people who transition from moderate to severe or get started on therapeutic dose heparin on the ward and go to the ICU, because those patients did worse in the ICU. Like, should we stop it? And the answer is we have no idea. And I will say that the data that I presented that showed therapeutic dose heparin in moderately ill patients, those not on organ support at baseline, the data that I showed that therapeutic heparin is beneficial included a protocol that continued the therapeutic dose separate if patients transition to the severe state. And that's the trial that concluded and will be published as beneficial. And so will your patient derive more benefit if you stop therapeutic anticoagulation when they go to the ICU? I don't know, maybe. Will they derive less benefit if you stop it? Maybe. And so I think that there's a legitimate uncertainty on how to manage those patients. And I might suggest in those patients, you do what you normally do in the ICU, whether that's intermediate dose or whatever you do. And there's no wrong answer because it's a question that now needs to be answered with randomized trials. I just wanted to thank, there's a lot of funders in this and partners. CanVector is really an important integral partner to the success of this study, who are part of the protocol development, adjudication of outcomes, patient partners, etc. And it's been an incredibly productive partnership with thrombosis experts in Canada, and others listed on this screen here. Thank you very much, and I'm happy to answer questions.